Among the IMGs, there are some challenges that we have
Yes.
observed. In your experience, what are the reasons the IMGs struggle?
Yes, it's a constant concern, that, isn't it? I suppose let's keep it in proportion to this exam is no different from any other medical exam. In fact, in this country, many exams from other professions, from law or accountancy, experience that same cultural gap between the performances of candidates who've grown up and have been educated in the UK system and the UK culture, and others who, for various reasons, have come to this culture later in their life, where English is probably not their first language. Um, there are various things that the college tries to do to reduce that. They call it an attainment gap. That's the jargon for it, and it's by no means peculiar to this exam. It's a universal finding in all medical exams. I think what's at the bottom of it, we can't deny that language does come into it. I mean, I speak French reasonably fluently, but not fluently enough to be able to work as a clinician in France and understand all the nuances. And I wouldn't expect to. I would find that very difficult, and it wouldn't surprise me if my French patients found it difficult to talk to me. And I think the same is bound to apply if a patient has difficulty in being understood or difficulty in understanding what's being said to them. I'm afraid that cannot fail, but to make for a more difficult consultation. Um, but having said that, I mean, in my experience, the command of English of our IMG colleagues is fantastic. I mean, really admirable. So I think probably a greater cause of it um, is the fact that many people who've qualified overseas have worked and been educated in healthcare systems where the dynamics and the structure and the expectations are very different from the UK. In the UK, in general practice now, as you know, the expectation is that it's more a conversation between equals. General practice is not a hierarchical profession. GPs don't sit within a hierarchy of seniors and juniors as our hospital colleagues do. And I think that transition from working in a hierarchical system to a non-hierarchical system is harder for IMGs in many cases for that reason. Um, and so I think that goes a long way towards explaining it. And I think the other thing is to many of our IMGs have had careers that have been perhaps they've probably spent longer in hospital medicine than some of our UK colleagues. Many of our UK trained colleagues go into general practice training straight after their F2 years, and tend not to have had their hospital styles reinforced by several years of hospital training. And I think that making that transition from a hospital style of working to a general practice style of working is more difficult. The more years you spend in hospital, the more entrenched that gets, and therefore the more difficult the transition is. I hope that makes sense. It's
Yeah, that makes sense. So we see the difference mainly in the clinical management, where what you've mentioned about the training and the hospital type of consultation where the doctor seems to know best is applied in the clinical management, and that's
Yes.
where it doesn't learn
That's true.
well.
That's true. Yeah, we use these phrases patient-centered and doctor-centered, don't we? We toss them around, and the general assumption is that patient-centered is good and doctor-centered is bad. Um, and that's not true, of course, and at least it isn't as simple as that. But I think if a doctor has a tendency to be doctor-centered, it tends to show most in the management part, where, of course, the doctor has some expertise and a greater knowledge of possible treatment paths and outcomes and so forth. Um, and it's very tempting a piece of behavior that we quite often see in less successful candidates when it comes to management is to say to the patient, right, you've got this condition and this is the treatment for it. You will now do this, I will now do that, and this is what's going to happen. And that may be good medicine, but it's forgotten that bit which I was talking about earlier. That doesn't necessarily satisfy the patient. Good clinical outcome is, of course, necessary, but it's not the whole story. And that good clinical medicine has to be involved, has to be supplemented, as it were, with does that fit the patient's expectations? Does it answer their questions? Does it set their mind at rest? Which is again the ideas, concerns, and expectations agenda coming into play. That tends to be the bit that gets lost in less successful management sections.
When it comes to advice, for example, let's say a patient is smoking and that candidate wants to advise a patient. So if somebody tells someone else what to do, it might not be taken very well. Whereas if we involve the patient, it's different, they're more invested. So tell us a little bit about what are the tips you'd give somebody in the clinical management, how to explain these advice.
The figures on how effective any GP is in stopping patient smoking are pretty depressing. I'm sure you've said, as I certainly have to in my time to various patients, that you really ought to stop smoking, and they say, "Yes, doctor, quite so, doctor," and go away and do absolutely nothing. So telling people what to do on things, particularly on lifestyle things, is totally ineffective. I must admit my inclination is to try to steer clear of that sort of thing, really. I think people who've got a chronic chest and smoke 40 a day know perfectly well that they ought to stop smoking. And being told that they ought doesn't actually add anything. So I think that there are better ways of helping people stop smoking than just kind of tacking the advice on at the end of a consultation about something different.
When you know the person much better, then you can use their concern that way. They might be more alert as in the problem when they're smoking. For example, let's say if you've got somebody who has problem with fertility and they're smoking, if we link that the problem with fertility and the smoking, then they might be more incentivized to stop smoking.
Yes, I'm sure that's true. Yes. I mean, it's all about motivation, isn't it? I mean, within limits, you can do more or less anything, provided you're motivated. So generating the motivation, I tend, this isn't necessarily relevant to the exam, but I've had quite an extensive background in clinical hypnosis, where sowing the seed of an idea or a suggestion is much more powerful than a direct order.